All right, it's 12 o'clock, so we'll go ahead and get started. This is the 8th session of the PPCL Provider to Provider Consultation Line, Perinatal Mental Health Tele-Echo. Today's focus is on intimate partner violence. But I want to welcome everybody and thank you for joining us today. This is our agenda. We're going to move pretty quickly through it to give everyone the maximum amount of time to participate. We'll do some brief introductions, then I did it anyway. Jocelyn Pinkerton will lead us through the didactic presentation, and then Haley Verrett and Dr. Olivier will do a case presentation with time for clarifying questions, and then we'll take recommendations, which will be sent out to everyone that is attending, as well as the didactic slides will be sent out to everyone that attends. And we'll wrap up with announcements and the survey link if you need CEUs or CMUs for this program. So some brief introductions first. I am Jody West. I am the coordinator for the ECHO, but I'm the program manager for PPCL. We provide mental health consultation to providers across the state of Louisiana for either pediatric or perinatal clients or patients. And pediatric is 0 to 21. And perinatal is pregnant and 1 year postpartum. So providers like you can give us a call at this number. We also have an online consultation form request that you can fill out on our website that can ask a question if you need guidance or assistance finding resources and referral information for your patients or your clients. Also, if you have a medication or a diagnostic question, you can speak with one of our psychiatrists if you're a prescriber, or if you have questions to help guide treatment in your practice for your patient. So we don't directly interact with patients or clients. We interact with you as the provider, and then you provide that information to your clients. So if you scan this QR code, it brings you to our registration page, but you can also sign up with PPCL and register, and you'll get updates through our newsletters and other emails about other educational opportunities that may be available. I'm going to go ahead and hand it over to Dr. Olivier. She's going to lead us through the rest of the introductions of our hub team.
Hey, good afternoon, everybody, and thank you again for joining us. I'm Dr. Olivier. I'm a psychiatrist here in Lafayette, Louisiana, and part of the hub team of experts on this session. I'm also the facilitator for this session, so I manage the clock. But thank y'all for joining us on your lunch break. I'm gonna, as usual, ask the hub team of experts to reintroduce themselves, just for those joining us for the first time or for the 100th time. We always have a team of experts on these sessions representing different factions of mental health care providers. Our other psychiatrist on the call is Dr. Finelli.
Hi, thanks, Dr. Olivier. I'm Juliana Finelli. I'm a general psychiatrist and child psychiatrist at Tulane. My clinical focus is infant and early childhood psychiatry and perinatal psychiatry, and I get to work with PPCL as a perinatal psychiatry consultant.
Awesome. And you've already met Jody West, who's one of our social workers on our hub team. Other social workers on the call, Katie Abear.
Hey guys, I'm Katie Abear. I'm a licensed clinical social worker and perinatal trained, and I am also in Lafayette at Bloom Mental Wellness in private practice.
Thanks, Katie. And also Lena is another of our social workers on the team.
Hi, everybody. My name's Lena Reggett. I'm one of the social workers and mental health consultants for PPCL, and here today is IT support for the ECHO.
Thanks, Lena. And also representing both psychology and nursing is Dr. Zena.
Thank you. Yes, I'm part of the hub team. I work at Tulane in the Department of Psychiatry and Behavioral Sciences with lots of experiences in nursing and psychology with children, families, and young children and families.
Thank you, Dr. Zena. I'm going to turn it over to our presenter for today, Jocelyn Pinkerton. You can go ahead and take it away for about the next 20 minutes.
Okay, thanks. Hi, everyone. My name is Jocelyn Pinkerton. I'm also a licensed clinical social worker. And I've been working in the field of intimate partner violence for over 10 years now in the New Orleans area. So looking forward to talking with y'all today. We're going to talk about screening for intimate partner violence in maternal health settings. If some of this is a reminder for some of y'all, that's okay. I think it's just important to weave these conversations into this topic area. So I'm really grateful that y'all are having me here today. All right, next slide. and I'm going to move quickly because we don't have a ton of time. So we're going to just talk briefly about the definition of intimate partner violence. We're going to talk about screening and how to respond to patients who might disclose, and gaining some knowledge and confidence to promote survivor safety and connecting patients to resources. Next slide. So when we talk about intimate partner violence, we are talking about a pattern of behaviors used by one partner to maintain power and control over another partner in an intimate relationship. This could include physical violence, but it also includes emotional abuse and economic abuse and psychological aggression and stalking. The really important thing to note here is the key part of intimate partner violence is that there is that element of power and control in a relationship. I also want to say that, for the last several years now, Louisiana has ranked in the top 5 in the nation for female victims killed by male offenders in single victim, single homicide offenses. This is largely driven by guns. We have sort of the worst outcome for intimate partner violence is homicide, but we also sort of include a lot of other behaviors leading up to that definition, including emotional abuse. Next slide. I also want to just touch on sexual assault and human trafficking, because these are other forms of power-based violence. So sexual assault, our definition here, is sort of a form of power-based violence with a sexually charged act. And human trafficking is sort of the coercion or control for labor or sex. So these are all kind of like topics that are under this category of relationships that involve sort of an imbalance of power or control. And we're going to talk about how that shows up in perinatal settings. Next slide. So up to 1 in 6 pregnant women are reportedly abused by an intimate partner. And homicide is a leading cause of death during the peripartum period in the United States. In Louisiana, pregnant and postpartum women are more likely to be killed than die from any single pregnancy-related medical condition. So just want to ground us in the fact that this is a real concern for people in this population. And again, we sort of see these numbers about homicide as being the worst possible outcome. But I also really want to make the point that people who are victimized in the relationships also can show up in a lot of different ways that also contribute to medical conditions that contribute to our maternal mortality rate. So sometimes I've heard providers say, "Oh, we don't have people that come into our office. They don't really experience violence." They do. You might just not know about it. This is something that I want to note also, is that a lot of times power and control in intimate partner relationships can sort of risk can be heightened at times when we see major commitments. So could be moving in together, could be a marriage, could be a pregnancy, could be the birth of a child. But those can be times that sort of exacerbate one partner's kind of need for power and control over another. And we'll talk a little bit more about that as we go on. Next slide. I recognize also that I'm talking about pretty serious topics in a very quick way. So I also just want to recognize that. But again, I think weaving these conversations into conversation about perinatal health is really important. It's not something that I think we should shy away from as providers. So again, I want to underline that, our worst outcome here is sort of our homicide and maternal mortality and death. But experiencing power and control or being the victim of a sexual assault can also contribute to a lot of other medical pregnancy complications, depression, substance use, symptoms of PTSD that can really impact someone's pregnancy and sort of their postpartum experience. Next slide. Again, want to highlight the impact of sexual assault on pregnancy. So besides the fact that pregnancies could result from sexual assault, sexual violence survivors report a lasting impact of that trauma through the lifespan. And when someone gets pregnant, a lot of times there's a connection here between a loss of power and control over their physical body that kind of can mirror sort of that feeling of loss of control in a relationship or that someone experienced through a sexual assault. So this can be a particularly vulnerable time. I also want to mention that there is a correlation here between medical causes of maternal mortality and trauma. So coerced sex can look like an infection. Post-traumatic stress disorder from a traumatic event can show up as cardiovascular conditions, or hypertension can sort of show up as eclampsia. So there's a lot of connections here between power-based violence and pregnancy and sort of what we might see patients experiencing negative impacts. Next slide. Okay, I also want to say that there's a connection here with intersectionality and equity and disparity of impact. So women of color are disproportionately affected by sexual abuse, intimate partner violence, and trafficking. Similarly, in Louisiana, Black women are 4 times as likely as white women to die from pregnancy-related causes, which people on this call should be familiar with that fact. So it's important to recognize that these things intersect with each other. Personal experiences, identity, and historical trauma all sort of intersect here to affect patient outcomes. And the reason why I'm saying this is because if we don't acknowledge that, we can lead to higher probabilities of re-traumatizing our patients and perpetuate what this wonderful organization called the Black Women's Blueprint calls the abuse to maternal mortality pipeline. We as providers are can be part of that continuum, and we have the opportunity here to interrupt it through screening and having conversations with our patients about power-based violence. Next slide. Again, big topic I just covered in about 3 seconds, so I'm aware that this is brief, but wanted to acknowledge that. So we're gonna switch over. I wanted to spend as much time as possible talking about screening, responding, and offering support. Next slide. So I don't know if everyone is sort of a part of ACOG here, but I thought I'd root us at least in sort of some professional organization sort of statement on a couple of the topics that I'm talking about. So I want to start out with trauma-informed care. Hopefully this is something that most people are kind of familiar with at this point in their practice, but I want to talk sort of specifically about how this ties in with screening for intimate partner violence. So again, if we really want to address kind of someone who has experienced a lack of power and control in their intimate or sexual relationship, one thing that we can do is use trauma-informed care in our practice, and not just sort of like as a term that gets thrown around. What trauma-informed care means to me is that we are assuming that anybody that walks into our practice could have been victimized by intimate partner violence or sexual assault. And so therefore we are treating everybody with care and knowing that that could be in their background. And what that really looks like is giving control back to patients. So the way that we can exercise this in our practice is asking for permission, providing patients with a lot of information about what to expect and what's happening, sort of allow for changes in our care that might offer some more control to patients. So if we are using trauma-informed care in this way, we're actually promoting survivor agency for patients and addressing sort of rectifying some of that harm of that loss of power and control that they might have experienced in their relationship. Next slide. Okay, again, hopefully this is not new information for folks, but I also just want to mention that trauma and sort of the impact of intimate partner violence doesn't always look the way that we sort of think about it and stereotypes. A lot of times trauma can actually materialize as things that as providers might make us kind of annoyed. So someone who's really on edge, someone who has sort of problems participating in a conversation, someone who or struggles to participate in a conversation, someone who is really avoiding care, those all might be symptoms of trauma. And when I'm also giving a training like this, when I'm talking to any group of people, I'm aware that some of the people I'm talking to might have experienced the trauma that I'm discussing. And so recognizing that is a reality, that our patients might have had this experience, and allowing for the possibility that that might be influencing how they're showing up in care. Next slide. Okay, so we're going to talk about screening, and then I'm going to talk about why I actually don't like the term screening. But ACOG recommends that physicians should screen women for IPV at periodic intervals, whatever. This is sort of the official recommendation, and I do agree with this idea that we need to remember that screening for this is incredibly important, because that, again, sexual violence and intimate partner violence, we know is something that a significant number of our patients might be experiencing during this time in particularly. So we want to ask questions about IPV and sexual coercion, ideally face-to-face and in a private setting. What screening really is continued engagement with patients around this topic. So a lot of times when we talk about screening for a medical condition, let's say I'm screening for blood pressure, I'm going to measure blood pressure, and then based on what that measurement says, I'm going to issue a course of treatment, right? Sort of write a prescription or sort of decide what our course of treatment is going to be. I think it's challenging to apply that same idea to intimate partner violence or to sort of social determinants of health in perinatal settings, because we might ask somebody about their experience with this, and that's not really a reliable screen. They might not want to disclose that information or not even realize that they're sort of experiencing emotional abuse in the relationship, for example. So getting away from this idea of kind of asking about experience of violence to sort of check yes or no, and really thinking about screening as engaging our patients around this topic is what I hope we can move towards. So next slide, I'm going to talk about more specifics on how to do that. Okay, I really like this model for screening. This is from Futures Without Violence, and I'll put more information about them on the next slide. This is the CUES model of screening, and this is sort of what I like to recommend. So the first letter for the CUES model is confidentiality. And going back to what we talked about, trauma-informed care, we want to make sure that patients understand what they're getting into when we're having these conversations with them. And again, giving patients as much control as possible over their decision whether or not they want to disclose information to us. So always sort of making sure that you're informing folks about the limits of confidentiality. Or a lot of times people might think, if I report this to my provider, they're immediately going to report that I got sexually assaulted to the police. And that is not the case. That is not sort of part of our mandated reporting guidelines. So giving clarity on the confidentiality level of your conversation gives more control back to your patients, and that can help sort of address that trauma-informed care piece. Next thing is universal education. So again, we might ask somebody about their experience and they might not want to tell us, and that's okay. So in order to incorporate that concept into our idea about screening, we want to ask people about this, but also provide universal education, letting folks know that they're not alone, that you are a safe person to talk to, and that this is something, relationships have an impact on health. And that's why I'm asking as a provider, is because, we know that, this matters as part of your postpartum experience and your perinatal care. The next piece is empowerment. So focus on listening and building safety rather than focusing on collecting information. So our goal here is not to make someone disclose what their experience has been. Our goal is to offer support and empowerment. And so even by having these conversations, that's not just a screen, that is part of your intervention, right? Is to offer support to the patient that you're discussing. So that's a really important piece, and it's sort of a shift. We're not necessarily trying to get information, we're trying to provide support and encouragement and listening. And then finally, support. So making a warm referral to resources and encourage health promotion and safety planning. We'll talk about that a little bit more later. So I just thought this concept at the bottom was really important. Women who received information about safety were more likely to report ending a relationship because the relationship was unhealthy or because they felt unsafe, regardless of whether they had disclosed a history of IPV. So even if someone doesn't disclose that information, you can still make an impact as a provider, and we want to keep that in the back of our mind. Next slide. Here's more information about Futures Without Violence and more information about the CUES model you can find. The big takeaway here is relationships can affect your health, and as healthcare providers, we can intervene and prevent violence. Next slide. Okay, I'm going to kind of breeze through this. Again, a reminder to review your mandated reporting so that you can have conversations about confidentiality with patients, that you might not necessarily need to make a report about someone disclosing abuse or violence if they're over 18. Next slide. Okay, so conversation starters. A lot of times I think our screeners ask a question, something like, do you feel safe at home? That's not necessarily a bad question to ask, but let's think about that as a way to start a conversation about, again, how relationships impact health. What's your stress level like these days? Have you ever been pressured into doing things that you don't want to do in your relationship? Let's recognize that IPV can be a part of the experience that our patients are having and open the door to that conversation if they decide that they want to. And if they don't, that's okay. They'll know that you care about this topic and that you're a supportive person. So just a reminder, everything you tell me is confidential. There are limits to that. So there's times that I might have to make a mandated report. Look, this can be a challenging time. We want to make sure that everyone's safe. Can I ask you a little bit about your relationships? Let's talk about how, this can be a difficult time. And this is talking about your relationship is part of talking about health. Next slide. And similarly, thinking about responding to disclosures. I think sometimes providers are scared to ask the question because what if somebody tells us this information that we don't know what to do with? And the takeaway here is you don't have to do anything. You can be supportive, you can listen, you can withhold judgment, you can acknowledge feelings. I'm so sorry that happened to you. That makes me really scared for your safety. Thank you for telling me. I believe you. What happened is not your fault. We have resources that are available. If you're interested, I can help connect you with some supportive services. So you do not have to have a solution. And in fact, it's probably better, again, in promoting trauma-informed care that you don't, right? That you are giving that choice and agency to your patient about how they're having this conversation with you and expressing care and support. Next slide. Okay. The Louisiana Domestic Violence Hotline from LCADV is a great resource for folks. This will ping to your local domestic violence shelter. Those shelters don't offer just shelter. A lot of times they offer safety planning, they offer legal assistance, they offer counseling. So if you don't know sort of your local domestic violence provider, looking at the Louisiana Coalition Against Domestic Violence is a great place to start. The Louisiana Foundation Against Sexual Assault also has a statewide hotline. This is confidential. People can call and speak to an advocate. So I would encourage you to find resources in your local area, but we also have statewide resources that can help you with making that connection. So again, sort of some examples here of how to have that conversation with people. Would you be interested in reaching out? I can help call with you. I can provide the phone number. Look, I just want to make sure all of my patients have this information because again, I know that this can be a challenging time. And even if you're not having this experience, somebody might be. And so we're just trying to spread information about resources for people who have experienced violence in their relationship. So again, some ideas of, make it authentic, make it supportive, but some ideas of sort of how to have that conversation with folks. Next slide. Okay, and then safety planning. So as providers, referring people, we have, great advocates in our state and great services that can help provide specific support. But as providers, you can also, have these conversations with patients. Where are you going home from here? Have you talked to anybody about this? Do you have a safe person you can go to for support? Do you need help connecting to any resources? Is there anything sort of that I can help you with making sure that you get to your next appointment safely? Do you want to think through some options together that might help you stay safe? So generally, people who are experiencing abuse in their relationship, they have a front row seat to what's going on. They know, and they are constantly making a calculation about what is going to be safest for themselves and their kids. So a lot of times they really know what's best, but it can be helpful to have a conversation with a supportive person like you as a provider who's going to resist judgment and just listen and be supportive and sort of help them talk through what that decision-making matrix might look like, and also has the ability to refer them to a professional who's going to have a lot more information about potential legal remedies or other things that might help support patients. Next slide. Okay, just a note on strangulation. I've seen, some screening questions for intimate partner violence go into detail about, what have you experienced in your relationship as far as what kind of physical violence. I do want to mention though, if anyone, if you are screening for strangulation or if any patients disclose that they've been strangled or choked, that is extremely dangerous and can be deadly if untreated. Not only is strangulation sort of a significant risk factor for later homicide, internal injuries can also, cause stroke or increased risk of miscarriage and sort of lasting physical implications that I think a lot of people don't realize. So if you hear this, you should be encouraging your patients to seek specialized medical care and screening, like a CT scan as soon as possible. So just kind of a public service announcement there. Next slide. Okay, I love this quote. We cannot force someone to hear a message they're not ready to receive, but we must never underestimate the power of planting a seed. As a provider, you might feel like you know all the information. This person just needs to get out of this relationship, right? But again, there are a lot of barriers to leaving a relationship, and leaving a relationship can actually be an extremely risky time. That's a time where we see violence increase. So we need to remember that if we do have a disclosure from somebody that they're making a lot of decisions and that they might not trust the criminal justice system, they might feel embarrassed or humiliated, they might be getting messages from their family that, you can't tell anybody about this. This needs to stay in the home. So there's a lot of barriers to someone accessing services. And this is complicated, right? The best thing that we can do is to sort of value someone and honor someone's experience and offer support and empowerment. But we aren't necessarily going to have all the answers, and that's okay. We can still show someone that we are concerned about their safety and that relationships impact health. Next slide. Woo, I think that's it. I think I did it in 20 minutes. So that's my contact information. I am really happy to continue having these conversations. If you'd like more information about how to implement some of this in your practice, if this was just a lot of information in a short period of time, please reach out, and I'd love to talk to you further about your thoughts about this. And I hope that this was helpful today. So I think that's all I got.
Thank you, Jocelyn. It's very helpful, and we appreciate the work you do as well.